Alright, sige. Feel na yun ako ang Zoom, dears, as in, promise. Charot. I feel like a legit lecturer. Thank you, MT Sock, as always. Alright, so again, dears, welcome to our continuation on fecalysis. No? And gahapon, may gani nakastart na ta, na humana na to ang macroscopic and all about the color, consistency, and whatever na mga characteristics sa stool, alright, which I believe is, of course, a review na on your part. Kay kapila na, so second year sa parasitology, and then ibalik na po sa third year AUBF lab na discuss na, so it's a review na. All right, so for this part we're going now to start with the main bulk of the analysis of feces. Again, take note, dears, for CM or for ClinMic, atong purpose of analyzing feces, it's not to detect parasite. Okay. Well, although part siya sa, or as one na, no, we heal as one, charot. As one ang section sa CM and para sa routine laboratory. For the CM mismo, no, we're after different substances or different other cells na nasa stool that can indicate disease. All right. And for parasitism or to detect parasites, good, that's in the parasitology na section. So for our discussion today, atong i-focus more are the microscopic exam on the different constituents of stool that may indicate an infection, okay, aside from parasitism, all right? Because again, we're done with parasitology, as in mga 50% of the didactics na time atong gahin, atong allocate for parasitology. All right, so starting first with your fecal fats, no? So for fecal fats, of course, unsa tong term na to, when there's an increase in fat content in stool, you have their steaturia. All right, so steaturia is described as increased fats in stool about greater than 6 grams per day, but according to Brunzel, pwede siyang greater than 7. Okay, so greater than 6, greater than 7 grams per day. So of course, the presence of increased fats in stool could indicate that there are probably a condition, there's probably a pathological condition happening inside the body of the patient, especially in the GI tract. And usually it's caused by two major conditions. You have malabsorption or maldigestion. So ito na siyang i-discuss or differentiate later. So for the screening test of your fecal fats, you have there, for screening test, of course, it's more on the qualitative, ayan, examination of feces for fat globules. So we stain the fat globules, that's why it's called qualitative. And for confirmatory, we perform quantitative to determine the amount, the concentration of fats found in the stool sample, all right? So we'll start first with the qualitative, which is your screening test again. So for qualitative fecal fats, again, you screen microscopically for the presence of fat. You look for mga fat globules or fat droplets. But of course, if walay stain or if normal wet mount ra, medyo lisod makita ni mga fat globules. So you have to employ the use of stains, of course, and we have discussed this sa imuhang microscopic example lang daan. These are your lipid stains, all right? Okay. Now, your qualitative fecal fats can be used to monitor patients undergoing treatment for malabsorption disorders. Again, malabsorption is one of the causes of steaturia, all right? Now, lipids included in the microscopic exam are, of course, the neutral fats or your triglycerides. You have the fatty acid salts, which are soaps na murag ni precipitate or murag ang solid portions of fatty acids. You have the fatty acids mismo and, of course, cholesterol. Now, take note, of course, for qualitative screening, we have to use the stains, as I've mentioned. And these are the lipid stains. And we have mentioned that already in your microscopic exam. Diba? Examples of these lipid stains, you have Sudan 3, Sudan 4, and oil red O. The most common being used is Sudan 3, okay? And of course, the droplets or fat droplets will be stained color orange-red, okay? Mga orange-red droplets, okay? All right. Now, still the same, parehas sa imuhang urine, no? Your cholesterol also will not be immediately stained by your by your lipid stains, okay? And also ganitong characteristic appearance sa imuhang cholesterol under polarizing microscopy, you have there, sa ngalan ato, on sa ihang description?
Maltese cross.
Okay, the Maltese cross formation. As long as, again, diba, it's within mga cells, mga tissues, mga casts, all right, sa urine. But if cholesterol crystals mismo, dili siya mo-exhibit yung Maltese cross formation, okay? Pero it's birefringent, okay? All right, so remember that. Okay, so that's for that's for qualitative fecal fats. And we have two major procedures. Number one, you have the neutral fat stain. So of course, neutral fat stain, this is to detect the triglyceride na portion. So what we use here are of course the Sudan 3 or Sudan 4, katong mga oil red O na to. And again, these fat globules will appear as orange-red droplets, all right, located near the edge of the cover slip. Now for the soap and fatty acids and cholesterol, they will not again be immediately stained by this mga kanina mga stains, all right? So therefore, we have to perform a second procedure, which is kaning split fat stain. Okay, so that's another slide. But first, we'll talk about the neutral fat stain. So again, for neutral fat stain, what we use is again your lipid stains. Okay, the lipid stains. So what we first do is we emulsify the stool, or we make a stool suspension. We add 95% ethanol, all right, and then add the stain. And then of course, you then look for the orange droplets, which will then serve, or which will then indicate the neutral fats. And greater than equal to 60 droplets per HPF, it is indicative of steaturia. So you have to examine the entire cover slip, all right? And then lantawa, i-average na lang per HPF pila mo nakita. If greater than equal to 60 droplets ang naa, then that's indicative of steaturia. But take note also that again, there are other causes or other fats that may be found in your in patients with steaturia. And again, these cannot be stained by the neutral fat stain. That's why we have to perform in another slide, second slide, the split fat stain to detect the fatty acids. So what do you mean by split fat? What you do first is mo sang i-heat ang sample. All right? So basically you're saying parang i-split, mo siyang i-open, no? Para ma-stain siya. Okay? So your procedure, emulsified stool plus 36% acetic acid this time, and Sudan 3, and please take note, i-heat siya, all right? And you then look after na for the orange droplets. And this time, we also have to measure the diameter of your droplets. So ang normal is 100 droplets, ihang size is about less than 4 micrometers. For slightly increased 100 droplets, ang range sa ihang size kay 1 to 8 micrometers, ihang size. And then for increased, you have 100 droplets, 6 to 75 micrometers ang imuhang size. But take note, di ba, medyo nag-overlap sila. Kaya you have normal less than 4. So you have to look at the droplets good. Pag measure nimo, if majority good kay less than 4 lang, all right, then you say that that's normal, all right? Pero kung naay mga variations, let's say mabot na siya greater than 4, no? Like 1, naiuban na 1 micrometer, naiuban na 5, naiuban na mga 7. So since it's 1 to 8, within 1 to 8 man siya, so that's 100. That's considered slightly increased as long as makita ka 100 droplets na inana ang murag size range. Okay, all right, so that's for normalness. So what if tanan kay 4 micrometers, asa man ako na siya ibutang? Okay. So ato na lang ka sa normal, kay that is the upper end na gyud of normal. But if mabot nag 5, mabot nag 6, 7 nya daghan kaayo, pwede na siyang slightly increased, okay, or increased. But usually if increased na gyud siya, then the droplets can vary in size. Dili gyud siya uniform na 7 tanan or 6 tanan. So most likely maka-aid pud siya in determining kung sa siya increased ba siya or slightly increased. Okay, all right. So here are some examples of your fat droplets. Ayan, as you can see, di siya klaro, pero muna siya, no? Orange-red na droplet. Okay, that's your fecal fat, no? All right, so both of them, they exhibit orange-red droplets. Ang difference lang is sa split fat stain, you have to perform muna heating because again, you're detecting fatty acids, okay? And these fatty acids cannot be stained directly by the Sudan 3. So you have to subject them muna to heating para murag ma-split fat ma-open, okay? All right. Tapos your cholesterol di ay na-mention na sa neutral fat, it still needs heating, ayan, and it will form the characteristic crystals, no? Katong notched corners, ayan, katong mga rectangular na crystal. So same sa ihi na crystal appearance. All right? Okay, so that's for cholesterol. Okay, but again, generally, these two types of fats, no, bahalag unsa siya, they are significant both, no, because again, this can indicate the different causes of steaturia. Okay? All right. So for interpretation of your qualitative fecal fats, again, our two main causes of steaturia is your malabsorption and maldigestion. So nasa pangalan na, when you say malabsorption, wala siyang absorb og tarong. So there could be a problem in the intestines mismo, intestinal disorders, lining of the intestine, no? Basin overgrowth of bacteria, ayan, damage to the intestinal wall. That's why dili siya maabsorb og tarong. Whereas for your maldigestion, nasa pangalan na, wala siya na digest og tarong. Okay, because there's a deficiency in the enzymes, usually coming from the pancreas or from the bile mismo. Okay, so that's the difference. So malabsorption, okay, wala siya na-absorb og tarong, okay, could be na may problema sa intestine. Sa intestine ang problema, okay? Whereas ang maldigestion, wala siya na-digest og tarong. Because again, there are some enzyme deficiencies brought about by pancreatic or bile acid so insufficiencies. Okay, so ang problema sa maldigestion is nasa pancreas or sa bile. Pero for malabsorption, ang problema nasa intestines. Okay? All right. Ikutasan na po ko. Oh my goodness. All right. Anyway, now for the causes, how do we differentiate? For first slide, diba, the neutral fat, kung normal ra siya, okay, and then increase imong free fatty acids, then that's malabsorption. So it's talking more about on para ma-correlate nimo siya, because the neutral fat or triglycerides, it doesn't really need parang it needs tama ba? Malabsorption. Yeah. Normal naman, so meaning, di ba, triglycerides, kailangan silang enzymes such as lipase coming from the pancreas. So therefore, in this case, malabsorption man, wala may problema sa pancreas. So therefore, normal lang. But for free fatty acids, it's increased because again, the fatty acids are reabsorbed through the intestinal wall. And because sa malabsorption na may problema dito, all right? So dili siya maabsorb og tarong. Okay? So normal ra ang first slide, neutral fats kay nara may lipase and enzymes secreted by the pancreas, pero increased sa imong second slide kay dili siya ma-reabsorb og tarong, okay? Then that's malabsorption. For maldigestion, increased ang first slide, neutral fats, because again, possibly na wala na lipase or enzymes coming from the pancreas. Kaya na may pancreatic insufficiency or sa bile acids ba mismo. So increased. And for second slide, pwede siyang normal or increased. Because again, remember that those enzymes put secreted by the pancreas and the gallbladder, they can, and the bile rather, or mga substances found sa bile, they can also in some part they can also digest the free fatty acids. Okay, so basta take note lang asa sila mag-differ sa first slide. Okay, so first slide normal gani kay ang result malabsorption, pero kung increase na gani maldigestion. Remember lang again that the first slide is talking about triglycerides, and usually triglycerides, they need an enzyme such as lipase and all that to be digested, and lipase is secreted by pancreas. And remember that maldigestion happens if there is pancreatic insufficiency. Okay, so sa muna mo increase imuhang neutral fats sa first slide in maldigestion kay possibly wala na enzyme lipase coming from the pancreas padulong sa intestine, because again ay problema sa pancreas, hence resulting to maldigestion. Okay, so I hope nag-gets lang to siya. Okay, so that's for maldigestion versus malabsorption. Okay, all right. Now, of course, if you want to confirm pag yun, then you can perform the quantitative fecal fat. So this is considered to be the confirmatory test for steaturia. Now, take note, dears, again, what I emphasized kahapon, basta ang question gani, which of the following tests required a timed stool specimen or a 3-day stool sample na huwag na mag-isip? That is for quantitative fecal fat testing or quantitative fecal testing, basta quantitative. Okay, all right. Now again, patient must maintain a regulated intake of about 100 grams per day of fat, okay, before and during collection period, para at least murag makabalo jud ka na naray source of fat. So murag makaingon jud ka na murag na-jud kay fats na makitaan pud sa stool kay na may source of fat. Okay, and then method routinely used is the Van de Kamer or Van de Kamer titration method. Okay, so you can also use gravimetric, near infrared reflectance spectroscopy, nuclear magnetic resonance spectroscopy, and other methods. So na ibang mga methods, pero the reference method is still Van de Kamer titration method. So reference values are 1 to 6 grams per day, diba? Of course, that's the normal normal, or iyahang coefficient of fat retention is at least 95%. And that's the formula for percent fat retention. You measure the gram fecal fat from titration and dietary gram fat based on the food that they eat. So given man na siya sa mga nutrition facts, whatever. And then imong i-compare, imong gaman o percentage. Okay, and dapat 95% siya and above, at least 95%. Okay, and that's the normal. So if below than that, then possibly na ay wrong or na steaturia na nahitabo. Okay? Kay percent fat retention man, meaning the amount of fat na imong na-retain sa body. Okay? So, kung daghan kayo kang, kung daghan ra ang nasa sulod mo, so meaning, wala ra kay steaturia. But if decrease mo ang percent fat retention, meaning, daghan kang fats na gipagawas. Okay? So, that's steaturia. Okay? Alright. Now, of course, that's your Van de Kamer or Van de Kamer. It's still considered to be the gold standard test for fecal fat determination. For definitive diagnosis of steaturia, and you use again a titrant known as it uses the titrant sodium hydroxide, and it's a mong indicator phenol red. Okay, so sample is again 3-day stool. Basta ang question, which of the following uses a quantitative fecal stool sample, or which of the following uses a timed pala, which of the following uses a 3-day stool sample. You have quantitative fecal fat testing or quantitative fecal testing. Okay, normal values again 1 to 6 grams per day, and for steaturia it is an increase in greater than 6 grams per day. All right, okay. Now so Strassinger, summary of different fecal fat analysis. Again, putting steatocrit and acid steatocrit. So it uses para hematocrit na centrifuge. So imuhang kwaon, imo siya i-separate, and then you then perform gravimetric methods to measure. Ayan. Then fecal elastase 1 is using immunoassays. Near infrared, what you use kay na ay spectrophotometer din ay computer software. Katuman siyang ano no, like murag imo siyang infrared light, imuhang stool sample, and then i-measure ang fats from the stool sample based on the infrared light na measure. Parang ganun, yeah, that's the principle. Van de Kamer, katugyapon, titration, and nuclear magnetic resonance spectroscopy. Microwave ang imuhang specimen, i-microwave siya, and then you use a hydrogen nuclear magnetic spectrophotometer. Again, most of the procedures are very high-end and very, it entails no technical kayo and very expensive na machines. That's why your Van de Kamer is still being used routinely, because titration lang man siya. It doesn't really require that much of a lot of expensive machines and technicalities. Okay, all right. That's for fecal fat testing. And what are the possible causes of steaturia? Again, this is from your Brunzel. So as you can see, ang maldigestion, as you can see, it's probably from pancreatic insufficiency or sa bile acid mismo. So muna siya kung di-mention. Ang for malabsorption, again, it's more on the intestine. So possible bacterial infection, no? Na yung mga tumors, na ba yung mga inflammation sa mucosa. Alright? Okay, so that's for malabsorption and maldigestion, the different causes of steaturia. Okay. Alright, so that's for the fecal fat testing. Okay. Next test that we can perform is your muscle fibers. Wait, tama ba? Muscle fibers ang next. Okay. All right. Okay lang pala. I thought ano. Okay. Kala ko nagkamali. Okay. Next, you have the muscle fibers. Now, for muscle fibers, again, still the same. It's usually used for monitoring patients with pancreatic insufficiency, such as in cases of cystic fibrosis. And again, the increased in the number of undigested muscle fibers in your stool, or the abnormal excretion of muscle fibers in your feces, is known as creaturia. And how do we remember? Diba? Creato, so parang creatinine. So creatinine is found in muscles. Ayan. So creatinine, creatoria. Okay. Now, of course, ganun pancreatic insufficiency man. Because again, these muscles or mga proteins, right? Enzymes also are secreted from the pancreas to digest these proteins. So therefore, if wala siya na-digest, imuhang muscle fibers, so possibly yun na problema sa pancreas. Kaya wala siya nihatag og enzyme. Okay? Alright. Now, determination, the patient, of course, kailangan siya mukhaon og red meat in the diet. So, lami kayo siya dyan, no? Kaya makaano dyan siya meat, okay? But of course, na source of meat or meat fibers, alright? And it should be examined within 24 hours of collection. So, the stool sample, you emulsify it, you add 10% alcoholic eosin, and then you add a cover slip and then let it stand for 3 minutes. And what we do is we count the number of the undigested fibers. Entire slide is examined and exactly for 5 minutes. So sa mga undigested muscle fibers, ayan. So kung completely digested siya, dapat imong muscle fiber kay clean ang appearance, wala siya striations, meaning wala siya mga lines, okay? Pero kung partially digested, iyahang direction of the striation kay one direction. It's either vertical or horizontal lang. Ayan. So one ra gyud. Pero ang atong ganahan is the undigested, which is imuhang muscle fibers iyahang striation kay both vertical and horizontal. Ayan. So it goes in both directions. And muna siya atong lantawon and muna siya atong i-count, okay, in the entire cover slip. If the number is greater than 10 undigested muscle fibers, then that's positive for creaturia, okay? And it's indicative of possible pancreatic insufficiency or cystic fibrosis or pwede pong biliary obstruction. Because again, possibly, di ba, the bile duct medyo duol ra pud siya sa duct sa pancreas. So kung na obstruction dito, it prevents the secretion of enzymes needed for muscle fiber digestion, okay? So undigested muscle fibers atong i-check. All right, so here is an example. Ayan, so as you can see, the striations kay na ay silang tanan, right, in all directions. Ayan, na ay vertical na po horizontal. And then here, as you can see, mga dagko na muscle fibers. Again, that's the undigested. Muna siya ato ang i-count, okay? And if greater than 10 per HPF yung muna kitaan, then that's indicative of creaturia. Okay, and again, sa atong reagent, alcoholic eosin. Take note, there's a 10% alcoholic eosin. Kaya sa mga sa CM dears, common po na ng mga question kana mga what are the reagents used, no? Especially sa kaning mga tests. So what are the reagents used to detect muscle fibers? What is your reagent in your unsa ni? Your fecal fat testing, qualitative, in the neutral fat stain, in the split na. So you have to take note of the reagents. Sige, if makaya pa dyan ako na i-appeal sa makalat notes. Atong i-summarize ang mga reagents. Okay, sa mga test. Wow, Mark, grabe, kaya mo pa ba? Charot, okay, anyway. Ayan, sige. So that's for the muscle fibers. Okay, so again, purpose to detect creaturia. Okay, because the presence of increased number of undigested muscle fibers in your feces is indicative of possible pancreatic insufficiency or bile duct obstruction. All right. Next is, of course, the determination of the fecal leukocytes. All right. Now, for fecal leukocytes, of course, the presence of your neutrophils especially could indicate the presence of a condition, infection and inflammation, such as ulcerative colitis and, of course, bacillary dysentery. So how do we determine these fecal leukocytes? We have 3 methods. Number 1, you have wet prep, no, wet preparation lang. 1 drop of your liquid stool or the mucus gyud, kay of course daghang mga WBCs dito, plus 2 drops of Loweffler's methylene blue. And then you look now for the WBCs na mas stained sa methylene blue. Another is dry preparation. So you make a smear stool, ayan, imo na siyang i-smear sa slide, let it dry and then stain with Wright's or Gemsa, and then look for the WBCs. And then number 3, of course, the Lactoferrin Latex Glutination test. So this is an immunoassay. You detect for Lactoferrin, which is a protein or a granule secreted by the neutrophils. And the results are available in 10 minutes. So easy lang kayo. So usually mga test kits ni siya or agglutination kits yun. Okay, so it's detecting Lactoferrin. So it's an immunoassay. So na yung mga question dito na Lactoferrin can be detected where? Or Lactoferrin is a test to detect what? Letter A, neutrophils. Letter B, fecal leukocytes. Letter A, fecal leukocytes. Letter B, urine neutrophils, whatever. So of course, that is for fecal leukocytes. Okay, especially the neutrophils. Now results greater than equal to 3 neutrophils per HPF lang. So even at that little amount, greater than equal to 3 per HPF, it's already indicative of an invasive condition. All right. Now take note kinsa itong mga diarrhea, especially in mga diarrheic samples, no. Kinsa man itong mga diarrhea na IWBCs, of course, those bacteria na medyo dili kay tig-release og toxins. Okay? Those talaga that are bacteria in kanang sila gyud mismo ang nag-cause sa disease, of course. Kaya of course, so the neutrophils will be increased kay para kanon i-phagocytize ang mga bacteria. And kinsa itong mga walay WBCs or little lang, those that are toxin producing. You have Staphylococcus and Vibrio cholerae, all right? And mga viruses and parasites. So you may be thinking, sir, di ba ang Shigella, E. coli, produce toxins? All right? But again, generally po, aside from they produce toxins, sila po jud mismo ang nag-cause sa disease. Okay? So for diarrhea without WBC, disease, katulad silang mga toxin-producing Staph aureus, di ba? Usually for food poisoning sa Staph aureus, it's the toxin that causes the symptoms, all right? And Vibrio pod, all right? And viruses and even parasites, okay? Could be there's an increase in WBCs, pero dili neutrophils, all right? So depending on the agent. Okay? All right. So that's for fecal leukocytes. Again, lactoferrin, para kakinsa ng lactoferrin, again, neutrophils or fecal leukocytes. All right. Okay. Next is, of course, ang pinaka-important yun na chemical analysis in your stool is your occult blood, of course. So the occult blood is considered to be the most frequently performed chemical fecal analysis, all right? Or fecal analysis, the most frequently performed yun. And when you say occult, diba, it means hidden. Because again, an amount of about 2.5 ml per 150 grams of stool is already significant. But this amount of blood cannot be seen macroscopically sa atong mga stools, all right? And that is what we call the occult blood. It's very significant, pero dili siya makitaan na sa imuhang, di pa siya makitaan kanina amount sa imuhang stool. That's why we have to detect this using different methods. And that is the testing for fecal occult blood, all right? Now, it has a high positive predictive value, meaning predict or taas ihang chances na makaingon na if positive ang patient, then of course, na siya possibility na mo develop ani na disease. And kung sa na disease, very important, it's for colorectal cancer. That's why it is recommended that mga patients aged 50 years and older, okay, should be screened yearly for fecal occult blood. Okay, so if na may mga inyong parents, yes, inyong mga tita, tito, yes, na medyo 50 and above na, so try to inquire sa mga doctors about it if okay ba sila magpa-FOBT, fecal occult blood. All right? Now, methods for detecting fecal occult blood, you have the guaiac, immunochemical, and fluorometric porphyrin quantification test. The immunochemical methods are, of course, the more sensitive and specific than the guaiac. Pero ang pinaka-common yun po na gina-perform are the guaiac. Okay, the guaiac fecal occult blood test. Okay? And what is the principle? Ay, wapade. Na. Okay. What is the significance, the eye of, again, occult blood? Still the same. Diagnosis of GI disorders, routine physical exam, routine hospital screening, and of course, the most important, mass screening for colorectal cancer. Because again, for colon cancer, colorectal cancer, pwede ang initial signs niya kay bleeding. Okay? And again, possible na ginagmay lang na bleeding, katurang 2.5 ml. And this amount of bleeding, as we have mentioned, again, it's not that evident. It will not be evident in macroscopic stool. Okay? So you have to detect that through the fecal occult blood testing. Okay? All right. Now, what are the precautions? Tama? Ang next, ayan. Patient preparation, again, of course, red meat free diet, of course, because this can interfere with the test. Okay, kay red meat free diet, so napa siya blood ginagmay, so possible na siya ang mo-react sa imuhang test. Next, you have avoidance of peroxidase rich food, of course, because of the principles of guaiac. Okay, so itong i-discuss later. Suggested diet and moderate amounts of food, okay, para at least dili mo interfere gyapon sa imuhang test. So para kakinsa ni siya, of course, not only for colorectal but also other GI disorders that may indicate bleeding, such as hemorrhoids, you have diverticulitis, anal fissures, colitis, and of course colorectal cancer. But again, the most important good is for colorectal cancer. Okay, all right. Now again, what are the test formats? Daghan kaayo. You could use benzidine, orthotoluidine, guaiac, the HEMA test, and HEMA screen. Okay, but silang tanan, ang ilahang principle is the same: the pseudoperoxidase activity of hemoglobin. So familiar lagi kayo ni sir. Asa man ni na principle po di ay kaning pseudoperoxidase activity of hemoglobin. Kakinsa kanina principle po aside from FOBT, guy. Kinsa man?
Blood, sir.
Blood sa
reagents.
Okay. Very good. Blood, the blood parameter in your reagent strip. So therefore, very okay na sir, I understand that. Sana naman. So that's the principle, no? Same ra gyud sila sa urine for fecal occult blood, the pseudoperoxidase activity of hemoglobin. So again, as mentioned, your hemoglobin in a way has an ability to become a peroxidase-like enzyme. So meron na siya peroxidase-like function. But of course, it's not an enzyme, okay? Pero na siya ability na mimic sa function sa peroxidase. So same principle gapon, hemoglobin which serves as a peroxidase, again, it will reduce peroxide and in turn oxidize the chromogen. And this chromogen, pag ma-oxidize na siya, it becomes a colored compound, which is what we detect, okay, in your test. So very easy lang, no, to remember. So muna siya, like, makathink ko na, anak ko na, ay, okay na ni, uy, ay, kanagin mo makathink ka na, basta mga question like which of the following, nato'y quiz bowl sa una sa September, PAMET quiz bowl, not this year, last year. No, there was a question, which of the following can cause a false negative reaction sa imuhang fecal occult blood testing using guayak. So, makating na ka dito na, my God, easy, press the buzzer. Kung unsay false negative sa blood, sa urine, mo po'y false negative dito. Kay same raman po ang principle. So, mangita dayon ka, og kinsa man tong pinaka-important nato na interfering substance for your, na makakause og false negative sa atong blood na reagent strip.
Ascorbic acid.
Very good. Ascorbic acid. So, pangitaa juday na kung na ascorbic acid. Kung false negative ha. So, kung false negative, pangitaa if na ascorbic acid, mag-press the buzzer na ka and mag-praise the Lord po kapag kahuman. Alright? So, inana siya ka, ano lang, kay same rabo principle. So, in a way, iyahang false negative, same rapod sa imuhang FOBT. Basta guayak. You mentioned na guayak or orthotoluidine or benzidine or hemascreen because they all follow the same principle. But if lahi na gani, immunochemical, you have porphyrin testing, lahi na po na siya na principle. So, dili na siya pseudoperoxidase activity. Okay? Alright. So, that's for your occult blood testing. So, for principle, again, what are the possible causes of false positive? Oh, alam niyo na. For 3 days sa atuang diet mismo because these food may contain natural peroxidases, okay, which can interfere or can interact with your method, no? So sila mo mahimong peroxidase, so positive siya, okay? Avoid for 7 days aspirin and NSAIDs because this can cause bleeding in the GI tract, tama, or this can cause GI irritation, okay? So although na eye bleeding na detect, it's not because of a problem in the intestine. It's because of a drug na naka-irritate sa intestine. So you have to avoid these drugs. Okay, para makabalo jud na ang positive good is because nadyo bleeding sa intestine mismo, not because niinom kog drug, not because kay nikaon ko. Okay? All right. So that's for false positive. For false negative, ayan, alam niyo na. Vitamin C, walang iba. Okay? Same principle with your urine na blood strip. So same rapod ang false negative. Vitamin C at concentrations greater than 250 mg per DL. So kana mga maglak-lak dira og beroka dears to mga whatever. Careful mo. Okay? And of course, iron supplements containing vitamin C. Basta ni ascorbic acid because again, that's a major reducing substance, no? And it can cause false negative reactions. Another is of course, duwa ka kahulat na mo react ang specimen. Kinagdali ka. So of course, follow the manufacturer's insert kung pila jud ka seconds, pila ka minutes i-process siya. Okay? Para follow jud the specified time. Okay? Sa reagent. Okay. So here's an example. Your hemascreen, ayan. Positive result name is color blue. Ayan. Because of the reaction of the oxidized chromogen, no? Ayan. So color blue siya. I'm not sure if naka-perform mo sa CM karon sa inyong lab o occult blood. Did you perform? Pero nako-video
Yes, sir.
Anara. Okay, very good. So hemascreen yung gigamit. Kaning alright.
Yes, sir.
Okay ra. So, very familiar na. But for dears, sa routine laboratory, ako na-experience sa Galyares, ako ma-remember, kaya daghang occult blood dito, immunochemical ilahang gamiton. So, what you do is, imo siyang i-immerse ang imuhang stool sample in anig yun. Mukuha ka usually it's recommended daw na sa center of the stool ka mukuha kung sample to prevent external, kanang sa kilid na possible na external interferences, contamination sa kilid. So it's best to collect samples at the center. So parehas ani sa immunochemical, that's what I experienced sa Galyares. Ilahang occult blood is in ani. So you, again, at least try to poke at different areas sa center para makakuha gyud ka. And then mo siyang i-immerse sa murag buffer na dala, okay? And then mo siya i-shake. So like oh my God. And then mo siyang i-shake until may homogeneous ang mixture. Ayan, until may homogeneous ang mixture. And then you drop, no? Yung mga pila ka drop sa test kit, and then you wait for the production of the results, no? So of course, if 2 lines, that's positive, and then kung 1 line ra negative. So for internship dears, I'm not sure if ilaha pa dyan pong ipadayon, you have mga quota, no? Like for CM na rotation, dapat maka-perform mo 10 ka FOBT, mga 10 ka UA, maka-perform mo 10 ka fecalysis, inana dapat makakita mo abnormal, makakita mo ova, makakita mo na mga inana na quota that you have to fulfill, no? So muna siya mo ibutang na sa inyong performance notebook mo na siya imong i-write dito. So sa government hospitals dili ka magproblemahan na gyud dears kay imong quota maglapaw-lapaw pag yun na siya. Pwede pa gyud na siya, pwede pa na siya ihatag sa imong other interns charot. Kay mag-apaw-apaw gyud siya. Di ka magproblema magquota dito sa imong government hospitals as in like usa ka shift nimo no like for example, first day pa nimo sa CM, nya kailangan ka og 20 na urinalysis na quota for the whole rotation nimo sa CM. First day pa lang nimo kompleto na. Wa na, human na, di na ka ma-problema. Okay na akong quota, sir. Ako na ipasa akong performance notebook. That's true, I'm not kidding. No? Fulfill gyud mo dayon nimong quota. Kay daghan jud kayong tests in terms of the workload and the load of tests na imuhang ma-receive. So minimum na lang na for CM na makadawat kag 30 na urinalysis in a shift. Minimum na siya, okay? It can even go beyond 50 or more. Okay, depende lang yun sa ano. My God, all right. So especially sa micro sa Soto Deers, my God. So what if ma-AM shift ka kanang 6 AM to 2 PM? Goodness gracious, as in magbaha ang sputum, especially kung Monday. And mo na, my God, kanatanan na sputum, usa ka patient, duha pag yun, duha ka sample. So what you do, imong buhaton na mo siyang i-coil, magama ka og slide for AFB testing and daghan kay na slide dears as in mabutog 100 and imo na siyang i-coil. So my God, kapoy kaayo gyud, no? So napay uban dito na napay request for sputum culture, so murag basta, ayan lang. Mga realities na medyo munang toxic yun ang workload when it comes to, I mean, any hospital din naman toxic yun ang workload, alright? But based on my experience, good, grabe jud ka intense ang workload when it comes to mga government hospitals. As in, like, kano sa panimahumaan, like, bago lang kanilingkod, na po iniabot, mga inana na level gani. Like, mabot na sa point na, usahay if mag-PM knock me na 16 hours, sa Galyares, makakaon na mi alas 12 na, alauna, alas 2, no? And then, ina na siya ka-busy, no? So, di kayo siya healthy, good for you. Pero gamay lang gud mi ato na medtechs pod or interns pod. So, sadya pod to siya. So, after na kayo magsabot mo sa mga huy, mag-milk tita, pag ganun. It's fattening. But anyway, ayan, so that's mga experiences, no? So, that's for occult blood, no? So sa Soto wala akong experience of occult blood sa CM, pero sa Galyares I did. Ilaha ka immunochemical, no? So mga test kits ilahang gina-perform. All right, okay. So depende kay na sa lab kung sila ganahan, napuyo ba na maghima screen yun, napuyo ba na immunochemical testing. But of course, ang immunochemical medyo mas paspas siya and medyo convenient po to perform. Okay? Pero baho gid siya. Actually for fecalysis good dears, no, like even now until like katong intern pagani ko di gyud ko ka di siya pa ako sa tolerate iyang smell. So after na ko siya i-process kay mugawa sa jugo kay I need to breathe. Okay. Naiuban siya ng mga stool good na uwiw baho ra jud siya kaayo gyud na dili mo siya kaya. Okay, bahalag ikapila baka mag-mask dira. So lisod gyud japon siya. Kailangan siya andanay. You have to be used to the smell. You have to be used to the appearance and all para gyud dili ka mag-overreact, whatever. Okay, and this is summary. Ayan, this is from Branzel. So for guaiac, again, pseudoperoxidase. For immunochemical testing, again, it's more on immunochromatographic kits. No? So labeled anti-human antibodies, i-capture ang globin portion sa imong hemoglobin, and then inato na. So of course, IS na yan siya. So di na ko elaborate ka baka medyo ma-TMI. Alright, for porphyrin-based, we use fluorescence because again, your heme, pwede siyang ma-degrade into porphyrins. And porphyrins, again, can fluoresce. Okay, so magamit tayo fluoresce. Fluoresce de Mayo. Magamit tayo fluoresce. Fluoresce de Belen. Fluorescence na microscope. Kailangan siya fluorescence. All right, my gosh, Mark, what's happening to your jokes? But anyway, okay, so that's for the FOBT. Again, very important yun. So, di ba, very dear, straightforward, especially when you go to guaiac. So, take note, dears, ha, if ang question gani kay guaiac, benzidine, orthotoluidine, kani sila, dears, muna sila ang chromogen. Benzidine is the chromogen, kung benzidine test, orthotoluidine ang chromogen, guaiac, siya ang chromogen, or katong mo ma-oxidize para may mong color. So, if ang question kay mga guaiac, benzidine, orthotoluidine, of course, that's directly yun, pseudoperoxidase activity of hemoglobin. Pero if mga immunochemical testing na porphyrin, then lahi na siya na procedures and principles. Okay? So, basta niya, makathink mo dayon dito ba na, makabasa mo, FOBT, ay okay, diretso, pseudoperoxidase. Basta lang tawag yun dayon ang question. Basahag tarong. Okay? Alright. Kaya basin dahil dili guaya kag mention. Alright. Next, another test is your apt test. So app test kay gikan sa name naka-discover sa test. So app test is usually performed para sa mga infants, para sa mga baby, mga newborns, because naay times na pagpanganak nila mas sila vomitus or ilahang emesis or nisuka sila og dugo, alright, or nagkalibanga sila og dugo. And we have to determine if unsay source of blood. Is it from maternal blood ba na ilang na-ingest during delivery, or gikan yun mismo sa ilang GI tract, which is much more significant. Kaya gikan yun sa GI sa imuhang newborn na bleeding. Okay? So, and that is the purpose of your app test. We have to differentiate the source of blood. Is it maternal ba or fetal blood? And what is the source? You have infant stool or vomitus. Okay? Now, material is tested muna in emulsified water to release hemoglobin, and then mo siyang i-centrifuge, and you have a pink supernatant. Okay? And then the pink supernatant, adan na to siya og 1% NaOH. Naku, there's kanina question, kanang app test, very common yun. Ang very common question na is, which of the following is the reagents used for the app test? Press the buzzer, you have 1% NaOH. Okay, so it's alkali. No, it's an alkaline substance. So, it's a principle because hemoglobin F is alkali resistant, meaning dili siya ma-denature by NaOH, all right? And hemoglobin A, which is your maternal blood, hemoglobin A, di ba, sa adult, is denatured by NaOH. All right? Okay, so what is expected results? All right? So, of course, again, procedure, emulsified stool, a centrifuge, and then you add 1% NaOH to supernatant, and then check the appearance of the supernatant. If it remains pink, ang solution, meaning the hemoglobin there was not lysed, okay, or it was not denatured. So, therefore, the hemoglobin there is hemoglobin F, gikan sa imuhang infant. Because we mentioned that hemoglobin F is alkali resistant. Dili siya ma-denature by NaOH. Whereas, if ang imuhang solution ay mo siyang yellow-brown, meaning na denature ang hemoglobin by your alkali or your NaOH. So therefore, that is maternal blood. So here's a picture example. Ayan, nakalibanga siya o parang stool, alright? Okay, na parang na-bloody. Now, take note there, dears, you cannot use a black tarry stool here. Okay, it means that the hemoglobin has already been degraded. Nasa sulod pa lang. So therefore, dili na siya ma-detect sa imuhang app test, because remember that the app test detects hemoglobin na intact pa lang. Okay? So kung black tarry stool na imuhang patient, pwede na siya, dili na siya magamit as a sample. Kaya it means that the hemoglobin has already been degraded sa sulod, so di na siya pwedeng makareact sa alkali na reagent. So here's a picture. I think gi-black na ni siya, pero basin red yun na siya. Okay? Alright, sige. So just an illustration. Alright? Okay. It also, this stuff distinguishes only between hemoglobin A and hemoglobin F, but also between the maternal hemoglobins AS, CS, SS, and hemoglobin F. Okay? So mga different hemoglobin mga types, all right, pwede siyang ma-differentiate yapon. But of course, to better differentiate you, if na mga abnormal hemoglobins such as AS, CS, SS, electrophoresis is much more recommended. Okay? All right, so that's for the app test. Again, para ni siya kakinsa, mga babies. Okay, oh my God, it's raining. Kulbaan ako sa akong connection. Oh my goodness. All right, sige. Now, next chemical exam is of course for fecal enzymes. Okay? So for fecal enzymes, ang pinaka-important ani, dears, is we're detecting your pancreatic insufficiency, because majority of the enzymes that are needed for digestion comes from your pancreas. All right. So therefore, if there's a decrease in the number of enzymes in these, when we examine the stool, then of course there could be a problem with your pancreas. All right. So this is seen in disorders such as pancreatitis or cystic fibrosis. So of course, steaturia occurs, and undigested food also appears in your feces. So what are the major fecal enzymes? You have trypsin, chymotrypsin, usually for proteins, and of course, elastase 1. All right. So you have trypsin, again, is useful for evaluating pancreatic function. And for cystic fibrosis, on sa mga test, you have the X-ray film test and the gelatin digestion test. So for X-ray film test, positive is of course ma-clear ang imong X-ray film because trypsin works on the X-ray film. And if negative ang trypsin, it is seen in cystic fibrosis. And for gelatin digestion, of course, ma-digest ang gelatin. Kay trypsin works on the gelatin. So positive siya, digestion of gelatin. For chymotrypsin is considered to be the more resistant to intestinal degradation and a more sensitive indicator of the less severe cases of pancreatic insufficiency and capable of hydrolyzing gelatin. But ato ang main method is spectrophotometry. And the last enzyme is you have joke pala pa ang procedure sa X-ray film, emulsified stool, imo na siya ibutan dahil sa X-ray film. If the stool contains trypsin, the X-ray film will be clear. So that's positive for trypsin. Normal lang iyang pancreas. Kung no clearing of film, like okay ra ni maintain ra yung color walay clearing, that's negative for trypsin, so that's a problem with the pancreas. Okay? And last enzyme is elastase 1. Siya gyud ang pinaka-resistant to intestinal degradation. So therefore, siya gyud ang most sensitive indicator of pancreatic insufficiency. So if there will be a question there, like which of the following enzyme is the most sensitive or it's the best marker no for pancreatic insufficiency, then you answer elastase 1. Or pwede na yuban elastine, no? Basta elastase, elastine. Okay? And how do we determine this? Immunoassays. Kato atong na-mention, ELISA. Alright? Pwedeng ELISA. Alright, so that's for the fecal enzymes. Okay? Madungan pa ko, dears. Okay ra? Wala ra ni anything. Kulbaan ko. Okay ra? Okay, sige. Okay. Diba sa niya mo, no? Pero I think mo notify maning ano no Zoom if ever ang connection kay something. Oh, Lord, my God. Rain, go away. Okay. So, alright, sige. Next, you have, of course, the gelatin digestion test lang na procedure. Ayan. I'm not sure if naka-perform mo ani sa CM, pero in a way, di man po kayo siya routinely perform. Pero it's to detect trypsin. Ayan. And ang positive result nato, dears, the fluid remains, the emulsion, the stool suspension remains fluid because again it indicates that trypsin digested the gelatin na imong gi-add. So therefore your stool contains trypsin. Pero if mugahi gani siya, then that's negative for trypsin. Kay wala man ang imong gelatin ni gahi or imong stool suspension that contains gelatin ni gahi siya kay wala may trypsin sa stool na mo digest sa gelatin. So ang patong positive result dapat mixture remains liquid. And again, that's the normal result or that's the normal, that indicates na normal imong pancreas. Okay? All right, sige. So that's for gelatin digestion test. Next test, you have the fecal carbohydrates. All right? For fecal carbohydrate, this is usually used for detecting kanang mga in cases of lactose intolerance, no? In cases of inability to absorb carbohydrates, such as in celiac disease or in the deficiency in digestive enzymes such as lactase seen in patients with lactose intolerance. So kato mga dili kainom og gatas, diba? So gamay lang na gatas sila explosive diarrhea, intense na kaayo, mag flatus, no, puno kay hangin iyang tiyan because again what's the enzyme that can digest lactose. So what happens, ang bacteria sa sulod, remember, diba, those are Enterobacteriaceae and a lot of the enterics are lactose fermenters. So therefore sila ang gamit ato mag-hallelujah ang bacteria sa sulod, okay? And ilahang production or ilahang byproducts, of course, massive gas na ma-produce. Okay? So muna utot-utot ka dito, flatus, and then magkalibanga po ka. Okay? Alright, ayan. So careful mga lactose intolerant dyan. I'm sure, I know lami man dyan ang milk and mga milky-like substances. Tsaka lang, yak iyo. Basta mga milk, no, lami man dyan ang milk. So careful lang. You can opt for mga plant-based milk, no, such as mga almond, no, such as mga soya, oat milk. Yes, yeah, that's lami ang almond. That's my milk na karon. All right, and other milks. Tsaka lang. Okay. Plant-based milk. So I think mas dili siya. I think it's a healthier and pwede siya for mga lactose intolerant na mga patients. Okay? All right. Now, testing for fecal reducing substances, of course, lactose, diba, is a reducing substance. So it can detect congenital disaccharide deficiency. So wala kay enzymes again for lactose or disaccharide, yes. And it's most valuable in assessing cases of infant diarrhea because of lactose intolerance and maybe accompanied by a pH determination. So how do we determine? Clinic test, of course, your reducing substance na test following the principle of copper reduction. We mentioned that already, that lactose is a reducing substance. So pwede niya ma-reduce ang imuhang copper sulfate to copper oxide. Greater than 0.5 grams per DL is indicative of carbohydrate intolerance. And for fecal pH, your pH becomes acidic because remember that, of course, byproducts of fermentation includes acid, okay? And that can lower the pH, okay, of your feces. Okay, normal stool, dapat mga 7 to 8 lang medyo alkaline. But for carbohydrate disorders, pwede siyang maabot og less than 5.5. All right, take note of that. All right, now summary, dears. Ayan, for fecal screening test. Ayan, na-mention na here at mga discussion, no? So this is from Strassinger. Ako lang di-appeal para summarize na. Okay? And for last parts na lang sa ato ang fecalysis, mga diseases na lang niyo siya. Okay? Alright. So we'll start first with your celiac disease. Ayan. Now for celiac disease, this is an autoimmune disorder actually. And it's considered to be the most common cause of malabsorption in developed countries. So what happens in celiac disease? This is a disorder in which individuals predisposed, no, especially genetically predisposed, ingestion of gluten. Okay? So gluten is found in your wheat and mga grains. All right? So that's why, di ba, importante mo na yung mga gluten-free na mga pagkaon, alright? Because again, there are people that are sensitive to these types of food, alright? And sa gluten man good, there is an alcohol-soluble portion known as gliadin, and this gliadin elicits an immune response, all right, for genetically predisposed individuals, kay dili nila madigest imuhang gliadin, okay? All right. Now, celiac disease, again, it develops in persons ilahang HLA, kung nasa sila HLA, DQ2 or DQ8, Dairy Queen. Oh my God, I miss Dairy Queen. Charot. Ayan. Ang sarap pa naman. Okay, as in. So if mag-enter mo sa Cebu, ayan, samot na sa Chongwa, Fuente, o sa Soto. So you have two Robinsons there. You have Robinson's Cybergate and Robinson's Fuente. Ayan. So my God, kadaghang pagkaon dito. And you have the Fuente Circle. So daghang kaayo, my God. So, oh my God, next year pag yun, January. Girl, oh my God. So if mag-Cebu mo, oh my God. Yes, that's the best if second sem na Cebu kay na sinulog. Okay? Ayan. And girl, my God, sinulog. My God, one of the best na experiences yun. Sa Mango Avenue. Ato bang walay pandemic. I'm not sure karon if next year ba na napay sinulog na katong intense. As in, my God, like Mango Avenue ha. Sige, balik-balik to. And then, everyone na lang yun kim mo nang kaila. Like, tunulan lang kag, tunulan na lang kag baso na naimurag yellow na, alam mo na. And then, pahiran kag paint. Ayan. Yung balik-balik mo na niya, guot na kayong everywhere, kay murag daghan kayong tawo niya, skin to skin na mo ba niya, wala dyan mo kaila og everyone, basta na mo'y kuyog, and then, pahiran na lang kag paint. Ayan. So, yun po siyang pahiran balik, pero yung mga bet, kay murag, charot, ganung level. So, girl, oh my God, I'm telling you talaga. Okay. Scary daw. Sorry. Okay, sorry. Sorry. Ano say insert, sir? Or sa surface of the stool? Wala ko gets. Scary. Sus, maka-scary mo rin yung mga ano ni sila. Anyway, yeah. Basin wala pa yung sinulog next year. Pero I'm just saying, no, like, oh my God, that's true. Tama. Pero ako ka-realize na, ay, tama. Second sem, if mag-Cebu. Uy, my God. Sayang. Nice on ta siya if wala COVID. Okay. Na, kamoy mag-organize. So, pwede ra. Okay. Pwede na, kamoy na mag-organize. Pwede, like, funny pag ako. Sige, mag-chika na lang ako. Oh my God, mag-chika na po ko. Shucks. Anyway, sige na lang. So, what happened ato na time dears pag yun? What happened ato? Okay, nagpuyo ko sa Orhelio. Okay, so, makagets mo anif matumong Cebu. So, ang Orhelio, ana, dears, kay, basta, Jones Avenue na siya sa Cebu. Basta, ang point, ana, is like, during sa sinulog, on the day of the sinulog, may gani akong duty ato kay night pa, 11 p.m. Okay? So what happened ato kay during sa sinulog, wala dyan ay signal. Like whole day, wala signal. Kaya of course, to prevent mga, mga bomb scares, whatever. So what happened ato kay, kaning like, sa talay sa ako ang street, kay nakoy gikuha na shirt for my friends and kami na, nagsabot kami na magpalit og shirt and all kay para sa party. So what happened ay, kinisayo ko og mata, then akong gikuha ang shirt. Dayon, pagbalik na ako kay murag dili na ako kabalik sa ako ang dorm or sa akong gipuy-an because gilock na nila, like kanang giilang giharangan na ba, so ni cross ko sa Picas road, wala na ako kabalik sa akong balay until mga gabi na. So like may gani na ako'y friend dito na duol ra pod, nakistay ako sa iyang balay dito sa Shalom, ayan, which is duol ra sa VCMC. Okay, unsa na may na chika. Hoy, dili pwedeng mag-unay og batchmates. Pwede ra oy. Check. Take it from me. Check ra record ko. Ako ni siyang i-edit. I have to edit this. Pwede ra. Charot, check lang. Check ra. Kinsa man ka earns para mo ingon na. Joke lang. Pwede ra oy. Basta if kulang tag source of mga kabiga ato tas batchmates. Check ra. Check ra. Kung wala tayo source. Check ra. Bitaw, wala pa ko naman sa akong chika. But anyway, ayun. So, sa Shalom, no? So, Shalom, ilalom anak kay VCMC, Visayas Community. So, that's another hospital unta na affiliation sa internship. I'm not sure karon if naaba. But anyway, ayan. So, what happened na stuck ko dito dears as in for the whole day. Gabi na lang. So, what happened ato kay walay signal. So, dili mi ka text, dili mi ka tawag, may gani na rin connection or internet. So, pwede lang mo chat. So, nag-abot na may dito sa Shalom and then the rest is history. Starting sa afternoon until sa gabi, galakaw ra gyud mi dears niya. As in like, ano siya, like kanang, as in guot jud kaayo. So like, sa Jones Avenue, and then sa next anak kay Ramos man sa likod, no? And kana sila tanan muana sila sa Mango. So dito mi galakaw, gabalik-balik mi dito. And then ang Mango Avenue good years as in promise, like big populated, densely, dagan kasi kayong tao, promise niyo, murag, the smell is everywhere. And then, you know, like, ano, murag, girl, before mo magsinulog, pag deodorant, pud mo, ganong left. Mga inana na lang. Mga inana ba, na murag, girl, my God, what's happening here? But anyway, of course, dili na na siya ma-think about kay murag ano man na siya like kanang wala na kaga-think ba so murag kay imo dito kay party na lang and also moto. And then pagkahapon at 2 years as in bayin kapuyag yun naglingkod na lang mi sa Rob Cybergate as in kigipang kapuy na gyud mi as in mabuang ko like but it was like sadyag yun pagkagabi aton ta kay nauntay murag get together sa akong batchmates and other interns from other schools. But then if mo absent ka og duty katong sa Soto ato, imong absent is equivalent to 5 days of duty. So gating ko ato na murag, oh my gosh, kanang should I risk getting absent for 1 day niya kung ako siyang ilisdan og 5 days duty niya hapit na to padulong na tog end kay January na so wala lang. So my temptations na punggan na nako akong temptation ni duty ra ko ato nako sa clean chem section ato di na pud kay siya busy so 11 to 7 mi ato na duty so ga party pud mi dito. Yes, tama, nakaligo pud mi actually mang spray sila og beer, mang spray sila og water and magpahiran sila og paint as in like pag humanim to kay murag yun na gani kay murag mutapot ang paint pero matanta naman siya og water pero as in hugaw kay ko ato yun pero sadya sinulog the best, at least naka-experience ko sinulog at least once in my life. And yeah, no, wala mi kasimba ato which is supposed to be the reason nga tang nagsinulog no pero wala mi nakasimba ato kay medyo layo na siya sa Colon so murag sa Santo Niño na church so murag diretso na tayo sa girl ganun lang. But those were my experiences as in na-remember na ako kay January mo mag-start so very conducive for sinulog. So careful lang mo ha, your decisions in life. If mo absent ba mo kay remember 5 days siya para sa Soto depende sa ubang hospitals. Na uban na di gyud magpa-duty kung sinulog na uban na duty ra gyud as it is bahalag sinulog pa na bahalag mag-earthquake pa na duty ra gyud. Okay. All right, sige. So that's for nga to nabot dito sa Celiac Disease because of unsa nito atong point nga to nabot ato ano to? Basta, nabuta ditong dapita. Okay, alright. Last na lang akong chika, dears. Okay. Last chika na ako kay, funny kaayo kay, di ba mga letter V na school, di na ito ni-mention. Pero like, if like, itong mga first gina ako, na ba mga friends gina ako, na kanang dili jud arte, na kanang dili gyud kanang murag, kanang dili konyo, or dili pabebe. Na yung ba nagyod na pabebe? Ayun, sa kayo makabuwisnet. Pero like 9 times ito na, kanang mo break mo ba? Kaya of course, you need, like kanang sa motif gabi or para lunch break or dinner. So ngayon na salito na, huy, asa mo dinner? Ngayon na dito. So ako dito kay murag, ka-arty po na nila. Ano ba din? Murag anak ko dito, asa mo dinner? Then sila mo yung na, at dito sa Robay. Ako, saan ang Robay? Asa dito ng Robay? Then ano sila na, Robay good? Asa din ang Robay? Then I know it's Rob. What the fuck? Dito juga kayo na what? It's Rob na magunis amo dai. Dili mo ni Robay. So Robay dears. No, so it means Robinsons. Okay. Kaya doon lagi ka Robinsons ang duol sa Fuente, sa Soto and sa Chongwa na Fuente. You have Robinsons Fuente and Robinsons sa Cybergate. So Robay lahang pasabot is Robinsons. Alam niyo na. Okay. O, di ba? So at least karon matumog dumagete karon, matumi na. Kuya, magpadikaw ka. Kuya, ato ko Robay. So dito na. Okay ra ka dung, wa ka na lost. Asa man na Robay? Dapat nas kalindagan. Asa na napit? Charot bitaw. Ano na level no? Na-shook lang ko sa ilang pronunciation. Then ako over. Ganun lang. Anyway, alright. Wala ko naglagot ha. I love them. Charot. But they don't love me. Okay, alright. And mga proven. Oh my God. So, nag-chika ako sa experience sa Cebu. Sige, unya na lang na. Anyway, na-sidetrack na to sa ato ang disease, na celiac disease. Alright. So again, as mentioned, it's autoimmune disorder. Alright. And because of this autoimmune disorder, there could be damage, no? severe mucosal lesions in your intestine after exposure to gluten. Because again, pag kaon mo sa gluten, okay, gluten ha, na letter GL, charot, charot, okay, gluten, pag kaon mo sa gluten, okay, ayun, so mo react mo ang body, produce antibodies, causes inflammation in your mucosal lining, all right? And sa mga tests na to, you have the D-Xylose test, you have the immunologic test, of course, to detect antibodies. You have antibodies against gliadin, anti-gliadin, and you have anti-endomysial antibodies or connective tissue niya sa intestine. Another one here, dears, kinahong dimension, anti-transglutaminase. All right, so this is an enzyme found in the intestine that supposedly converts your glutamine residue sa gliadin to glutamic acid. But what happens is mo develop antibodies against that. So it's an autoimmune disorder. All right, so again, how do we differentiate? Una, the D-Xylose test. So itong i-mention ang D-Xylose. Ayan, so D-Xylose test is usually performed to determine what is the cause of malabsorption, all right, or maldigestion, especially if naay steaturia. Is it caused by pancreatic insufficiency ba, or is it caused by other causes such as celiac disease? So what happens is D-Xylose atong pakanon or paimon ng patient og D-Xylose, all right? And this D-Xylose doesn't require or it doesn't need enzymes from the pancreas to be digested, but it is absorbed by the body, all right, and makitaan po siya sa urine. Bahalag because dili siya kailangan ng enzymes sa pancreas, okay? Remember that. D-Xylose is metabolized by the liver, dili kailangan sa imuhang pancreatic enzymes to be digested. It's freely reabsorbed, okay? And it appears in the urine, okay? So therefore, atong specimen here is 5-hour timed urine specimen. So let's look at the results. If the plasma level is less than 25 mg per dl and urine excretion is also low, so therefore, the cause of steaturia is malabsorption. Remember, di ba, we mentioned that D-Xylose is readily reabsorbed. So therefore, kung mabadi ay imuhang plasma levels, wala pa gid siya nakitan sa urine, meaning wala siya na reabsorb. Meaning, na siya'y problema sa imong intestine. Meaning, na siya'y malabsorption syndrome. Possible celiac disease. Number 2, high xylose levels lang in the blood and urine. So therefore, normal ra siya. Okay? Kaya therefore, nakita na gyud siya sa plasma, nakita po siya sa ihi. Because we mentioned again that D-Xylose can be reabsorbed freely by the body and makitan sa urine. Okay? All right. So therefore, the cause of your steaturia could be pancreatic or bile insufficiency. Now, let's say high levels in blood pero wala siya nakitan sa ihi. So therefore, naay problema sa kidneys. Okay? So I hope na gets lang to siya. All right? So that's the principle of your D-Xylose test. Again, unsay grams, oral intake of 25 grams of D-Xylose. Imo siyang gidissolve sa water and then may pakaon sa patient. Okay? All right. So that's for the D-Xylose absorption test. All right. Okay. If ako i-describe ako ang experience siguro, mas sadya siguro sa Cebu for me based sa Bohol. I don't know. Namugot yung mga issues sa Bohol na I don't want to revisit. Nagikapoy ko deal. But anyway, sa Cebu kay medyo ano namugot to? Although kapoy sa Cebu kay medyo marakog na acclimate dito or something, basta chika lang. Okay, all right. Now, another intestinal disorder is, of course, diarrhea. So I think at some point of our lives, naka-experience kita diarrhea. Okay, now diarrhea is described as an increase in the weight of stool that is released about 200 grams per day and increased liquidity and frequency, meaning more than 3 times a day. Kulang na lang magbalay ka sa CR kay gasigidyo ka o kalibang. All right, so that's diarrhea. Increase in weight greater than 200 grams and increased liquidity, sige kang liquid stools, and frequency 3 times a day. All right. Now, acute diarrhea happens less than 4 weeks. Chronic diarrhea greater than 4 weeks. Now, major mechanisms, you have secretory, osmotic, and altered motility. Now, laboratory tests to differentiate, you have, of course, fecal electrolytes, fecal osmolarity or osmolality, and you have stool pH. So again, ito I discussed there's iyahang mga mechanisms, no? So you have here secretory diarrhea. So ang point sa secretory diarrhea, dears, it could be due to a bacteria or mga toxins that will induce the secretion of the intestines of various water and electrolytes. Therefore, na diarrhea. Kaya iyahang gina-push, no? Gina-induce ang intestine na mo secrete og water and electrolytes. And again, what are the causes? Bacterial, viral, protozoan infections, drugs, laxatives, kanang mga bigger line, kanang magpaniwang, yes, laxatives, no? Hormones, inflammatory bowel disease, endocrine disorders, neoplasms, and collagen vascular disease. So, akong friend, funny kayo, kaya nag-bigger line siya. Kaya na lang yung maniwang. What happened kay whole day siya nakalibang dears as in, like ano ito na siya nayot, siya nayot ka nang kulang na lang yun magbalay ko diri sa akong CR kay di na jud ko katindog kay pagtindog na ako, pagtindog na ako after some time kalibang ko na pug ko so mabalik na pug ko. So ina na siya kakapoy, no? So careful man ang mga laxatives ha. All right. So that's for secretory diarrhea, no? So these substances, they induce, no, they force or they increase the secretion of water and electrolytes into the intestine, which override the reabsorptive capability. So meaning ang point ana kay murag sige ra og release og water electrolytes imong intestine kay may na too much na dili na ko kaya kay ni over na siya sa akong ability to reabsorb these substances. So iyan ang gipagawas, ayan, that's why there's diarrhea. In contrast, you have osmotic diarrhea. There's retention of water sa intestine because of an osmotically active substance imuhang intestine, such as maldigestion, malabsorption, disaccharidase deficiency, amoebiasis, laxatives also, and antibiotics. Meaning sa intestine mismo, kani sila, they're osmotically active, meaning ilang ginapull ang water gyud, ilang ginapull ang water and all that, padulong nila, therefore, daghang water na ma-release, hence the diarrhea. Okay? And last, you have altered motility. So therefore, there is increased motility lang or heightened imuhang movements imuhang intestines. Okay? And that's hypermotility or pwedeng slow motility. Kung medyo hinay ang pagpass sa mga food, mga undigested foodstuffs imong intestine, of course, it leads to constipation. But kung enhanced gani hypermotility, okay? So therefore, paspas kayong movement, wala na sufficient time to absorb water and all the electrolytes. So therefore, you have diarrhea. Okay? So unsay causes? Irritable bowel syndrome, rapid gastric emptying, and dumping syndrome. Or your RGE is actually known also as dumping syndrome. So what happened is, after pagkaon pa lang nimo, after pila ka minutes or after pila ka hours kalibangon na ka inana, so mura siya RGE ba, so mura wala pa ni mo na experience fully ang kabusog kalibangon na ka, parang ganun, no? So after mo kaon malibang na kadayon ina, so rapid gastric emptying, dumping syndrome. So very heightened ang movement sa imuhang intestines, no? There's hypermotility. Okay, all right, so here's a summary again. Secretory diarrhea, ayan, so increased volume, fluid volume, increased solute secretions. Osmotic diarrhea na sa pangalan na there's an osmotically active solute in your intestinal lumen. So possible na maldigestion, kay daghan kay kang nakaon, daghan kay kang nakaon na something na medyo osmotically active, so iyahang gi-pull ang water towards it, so muna nagkalibanga ka. And intestinal hypermotility, of course, sa pangalan na heightened, no, imuhang movement, so there is a decrease in the time allowed for intestinal absorption. All right. Okay. And for differentiation na lang of your diseases, no? For fecal characteristics, if watery siya, then that's diarrhea. You then look for WBCs or the fecal osmolality. If na WBCs, then that's bacterial. So you request for stool culture. If wala WBCs, could be parasites or viruses. And then for fecal osmolality, if normal ra siya, you have secretory diarrhea. And kung high imuhang fecal osmolality, you have osmotic diarrhea. So possibly because again, di ba, osmotically active, so high imuhang osmolarity sa imuhang feces because again, daghan siyang gipool ng mga electrolytes and water. So therefore, mutaas po din mo osmolarity sa stool, all right? And mugama imuhang osmolarity sa imuhang system, okay, inside the bloodstream because again, na-pull siya towards the intestine. Then if greasy or bulky or foul imuhang stool, then that indicates steaturia. You then look for fecal fat determination. If normal ra siya, then of course that's normal. If abnormal, you rule out hepatobiliary or pancreatic disease. So you perform the xylose absorption test. If it's normal, okay, normal ang xylose absorption, then that's maldigestion. Okay, tama. So maldigestion, there's a problem in the pancreatic enzymes because again, di ba, D-xylose does not require your xylose, no? It doesn't require enzymes from pancreas to be digested. So therefore, kung normal ra imong D-xylose, it's possibly pancreatic or whatever, di ba? As we have mentioned. But for abnormal, di ba, katong low imuhang plasma concentration sa D-xylose, low pod sa ihi, then that indicates malabsorption. Because remember that D-xylose is freely reabsorbed by the intestine. So therefore, kung decrease iyang amount in the blood and sa ihi, it means wala siya na-absorb og tarong. So therefore, na problema sa imong intestine in terms of the absorption. All right? And then for summary of other tests, for mucus, you have the Hex Test, okay? So mga chemical test lang ni siya, light green against a dark green background, so staining. Bilirubin, you have the Gemelins and Huppert's, green color ang positive. Urobilin, you have the Schmidt's and Schlesinger's test. So positive is red for Schmidt's, and you have Schlesinger's kay green. Okay? And that's all for fecalysis. Okay? So that's the end na gyud atong fecalysis, which is our target because again, daghang questions based sa TOS ani. All right? So for the second nato na discussion, we'll go with gastric fluid. Okay? So ako sa stop dears ha. Okay, may makita kayo. Tsaka na. Okay. So kamusta man kayo dears? Any question di ay so far before we continue? All right. Kagapil po dyan ang gastric fluid. Kung kanigit silang Sir Leo. Charot. Tsaka lang. Okay. All right. Sige. Kamusta man dears? Are you still learning? Wow, yes. Okay. Okay, sige. So we'll continue again with your gastric fluid. So medyo short lang ang gastric fluid. Yes, makitan ra? Can you see it? Akong presentation? Okay ra? Yes, nandiyan pa ba kayo?
Yes, sir.
Okay, thank you. All right. So for gastric fluid, ayan, and duodenal contents, ako na lang siyang i-include. So nani siya sa notes si Sir Errol as in very short discussion lang because usually in the recent na mga boards, recent books na to sa, Clean Mic and all, wala na kaayoy i-discuss sa gastric fluid and duodenal content. So majority of the content here or the information came from mga old books, no, mga old references nato sa CM. Okay, so that's from my review notes. So majority sa atong notes here, information are coming from my review notes. Okay, so nara ka ng Sir Errol na notes dira. All right, so we'll start first with here, kaning picture, ayan, the production of your gastric fluid based on notes in Sir Errol. No, so we'll start first with your G cells. Okay, these G cells again can be found in the stomach. All right, and in the presence of food, no, especially mga protein na mga byproducts, it will stimulate G cells to produce gastrin, which is a hormone, and gastrin will trigger parietal cells to produce HCl or hydrochloric acid. And hydrochloric acid, it will convert pepsinogen, which is a precursor enzyme, diba, to become pepsin, all right, which is produced by chief cells, which then digests proteins. So therefore, that's the generalized production or generalized flow of the production of your gastric fluid. Your gastric fluid, of course, diba, dira sa HCl, dira ang atong gastric fluid, and also other components of your aside from HCl. All right. Now take note, we have two major diseases na itong ginalantaw. Number one, you have the Zollinger-Ellison syndrome. Your Zollinger-Ellison syndrome is actually a group of disorders. All right. And majority of that are usually mga non-beta islet cell adenoma of the pancreas. So they are what we call mga gastrinomas, all right? And these gastrinomas, by the name itself, gastrin, all right? So they continuously produce gastrin. So therefore, gabantay mo, gastrin, sa may purpose, iyahang i-convert or i-trigger ang parietal cells to produce HCl. So therefore, if siging taas imuhang gastrin, okay? Kung siging taas imuhang gastrin, so meaning, sige po kag-produce og HCl. So therefore, in Zollinger-Ellison syndrome, all right, increase imuhang gastrin levels and increase po imuhang HCl levels. So you will have hyperchlorhydria or hyperacidity. No, taas kay imuhang HCl levels. So therefore, for Zollinger-Ellison dears, what you have to remember lang yun, taas siyang HCl, taas siyang gastrin levels. That's why one of the tests that we can use for detecting Zollinger-Ellison is plasma gastrin assay, no? So we have to detect the gastrin levels. So if kani-gani ang question mo gawas, para asa ning plasma gastrin assay, it is for Zollinger-Ellison. And usually para unsay mga methods, mga radio immunoassay or mga enzyme immunoassays. All right? So plasma gastrin assay, that's for Zollinger-Ellison. Now in contrast, you have pernicious anemia. All right? So I'm sure you're all familiar na. Hima, kamusta tayo dyan? Of course, for pernicious anemia, it's an autoimmune disorder. So ang problema, you have antibodies against the particular constituents in your stomach. Number one, you could have antibodies against the intrinsic factor. All right. Number two, you have antibodies against the parietal cells. Now, take note that intrinsic factor is needed for the absorption of, diba, vitamin B12. And if wala kay vitamin B12, of course, diba, it can lead to megaloblastic anemia. So therefore, pernicious anemia is a type of megaloblastic anemia. All right. So, ang pernicious anemia, kabantay mo, you have anti-parietal cell antibody. So therefore, kung naka-anti-parietal cell antibody, ma-destroy imuhang parietal cells. And ano purpose sa parietal cells? Siya ang mo-secrete sa HCl. So therefore, if you have pernicious anemia, you have low HCl level. You have hypoachlorhydria or an acidity. Wala dyan kay HCl na makita. Okay, so take note of that. Pernicious anemia. All right, so it's autoimmune, ma-destroy imuhang parietal cells or the intrinsic factor. You have mga autoantibodies, no? Muna siya at autoantibodies sa pernicious anemia. All right, okay, so that's for the summary, no, of the flow of the production of gastric fluid. All right. Next, you have for physiology. Ayan, so ito nang i-discuss. Parietal cells of the stomach, kung siyang purpose, to secrete HCl and also intrinsic factor. And we mentioned, intrinsic factor is needed for intestinal absorption of vitamin B12. Kinsa ganitong parasite, nako, kani pa lang daan. Kinsa to na parasite na makompete for your sources of vitamin B12 sa imuhang lawas. Hence, can cause megaloblastic anemia also. Kinsa man to?
Dilatum.
Okay. Kaleng, dilatum, paspas. Diphyllobothrium latum. The tapeworm, fish, tapeworm, broad tapeworm. Nako, kalimtan na itong para, no? Yes. Okay lang. Sige, noted. Sige, kinsa naman puweta. Charot, tsaka lang. Sad boy yarn. Charot lang, bitaw. Tsaka lang. Alright, of course, I'm sure pag-review ninyo, anak po, dears, ma-remember na ninyo. So, okay. Alright. Magsalig ako sa inyong memory. Okay? Next, you have zymogen chief cells. Sila ang musecrete sa pepsinogen. Alright? Which is converted by HCl produced by your parietal cells, okay, to pepsin, which catalyzes protein digestion. You have the specialized G cells, nasa pangalan na, G cells, so therefore, sa iyahang i-produce, letter G. Gastrin. Okay? All right. And the foveolar cells, which are mga mucus-producing cells that lubricates the stomach to prevent the effects of the acidity sa imuhang lining sa stomach. Okay? All right. To protect the inside of the stomach. All right. Now, why do we examine gastric fluid? All right. Number one is, of course, to determine whether the patient has gastric juice or wala. No? Okay, again, such as in pernicious anemia, basin wala kay gastric juice or wala kay HCl na ma-produce. All right. Next, you have it measures amount of gastric acid that can be secreted by one with ulcer symptoms. Ayan, especially for mga ulcer symptoms, possibly ba if mo increase ba yung gastric fluid or unsa man gani, no? And of course, another is helps determine the disturbed function of the GI system. Aside from that, we can also look for mga gastric carcinoma in some way, all right, if we analyze the gastric fluid. Okay? All right. So again, now we go now to the composition of your gastric fluid. What is the normal composition? Of course, it still contains water. You have free HCl, of course, which contributes to the acidity. Okay? Next, you have pepsin and renin, which are enzymes needed again to convert or to digest proteins. Mineral salts, such as mga ACPs, mga enzymes pa rin. Particles of food, undigested and partially digested. And you have mucus in moderate amounts. Now, pathological composition of gastric fluid, you have organic acids such as lactic acid. So later, natay discussion on that when we go to lactic acid. Blood, of course. Bile, all right? Because again, remember that bile, dito na siya sa small intestine. So ano siyang naabot dito sa stomach, kay gastric fluid man. So there could be regurgitation, naibas in bile duct obstruction, ganun. Pus and mucus in large amounts, of course, so possibly na naagyo irritation or inflammation, and you have trypsin when found together with bile, regurgitation. Remember, ang trypsin, kinsa may nagsekret ana, you have pancreas, all right? And pancreas, di ba, remember, anatomy ninyo, diretso na siya sa duodenum, sa small intestine. So nga naman siya maabot sa stomach. There could be regurgitation, ibalik siya dito. Base na ay problema sa sphincter muscle nimo dito sa stomach that controls the passage of food or chyme, CHYME, from the stomach to the small intestine. So possible na yung mga problem na inana. Okay? So that's the pathologic and the normal composition of your gastric fluid. All right. Now, what is a specimen collection? What's the mode? Is of course mode of specimen collection. You have aspiration, and as siya paagi, it's either sa mouth or sa nose. All right. And very, 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 very press the buzzer na question, you dears. When it comes to gastric fluid, is kaning mga tubes. All right. Kinsa tong gipaagi sa nose, kinsa tong gipaagi sa mouth. Okay. Now take note. Ayan, we have majors dira, duha ka major gyud na tubes. You have one lang sa nose and the rest kay sa mouth na, okay? So kinsa tong sa nose ipaagi, you have Levin, okay? Levin tube. So how do we remember? Kung kinsa ang letter N, siya ang ipaagi sa N, nose. All right? Take note. That's our mnemonic. Levin, letter N. So kung kinsa tong letter N, dito siya ipaagi sa letter N, sa nose, okay? And si refus or refus, siya ang ipaagi sa mouth, okay? Actually, daghan sila na sa mouth. But usually, kani silang duhag yun ang gina-ask. Okay? So, Levin, basta na letter N, nose. Refus is for mouth. So, the different tubes for collection of gastric fluid. Okay? Take note of that. I have a strong feeling ba sinusan sa question na magawas sa inyong kompre. Sana naman. Okay? Alright. You have other tubes. You have the evacuator tube, which is sa mouth gyapon siya. Imo siyang ipaagi sa mouth and nakay irrigant, so meaning imo siyang ispill og water or fluid to facilitate the collection. You have the Ewald's tube and your Edlic's tube, parehas gyapon, to aspirate gastric contents quickly. But again, ako emphasize dears kanang first two, Levin, and si Refus. So si Adam Levin and si Refus. I think one of the mnemonics ato kay Adam Levin, kay si Adam Levine taas siya nose. Ayan. I don't know. I think that's one of the mnemonics na gi-share sa una sa review. So Levine, kay Adam Levine taas siya nose. But for me, mas effective ang naay letter N, Levin, siya ang ipagi sa letter N, sa nose. Okay? Take note of that, dear ha. Please don't forget that. Baka lumabas. I have a strong feeling na lalabas siya sa exam. Okay? Alright, sige. So these are the tubes, ayan. So sa mouth, and this is the refus. So kani siya sa Levin, sa nose gipagi. So it's aspiration padulong sa stomach. So gikan sa stomach. All right. Next, we look for after collection. Of course, we go now to we measure the basal acid output and the maximal acid output. So the bow and the mao. Okay. For bow, as you can see, it's the gastric secretion na unstimulated, fasting. Meaning, if wala ray food, wala ray anything, what is the amount of gastric acid released or gastric fluid by the released by the stomach? Okay, and it's a 12-hour overnight fast. No, water may be taken until 8 hours prior to the intubation to collect the gastric fluid. So you're determining what is the basal. No, kung say sugod jud basal, walay any stimulants, walay stimulation, walay any food, walay any stimulants na makapa-increase sa gastric fluid production. So duration of collection, 1 hour of collection. Every 15 minutes mo collect ka, and then imong i-add tanan. That's the sum of basal acid output. All right, and 2-hour collection you have for insulin hypoglycemia test. Now sa itong i-measure nimo ang volume, ang pH, and mag-titration po ka. And that is the amount na itong i-add every 15 minutes sa 4 ka samples, diba? So 15, 4 ka 15, so that's equivalent to 60. So 1 hour. Ayan, 60 minutes, 1 hour. So the sum of the acid outputs in the 4 samples, muna siya imuhang muna siya basal acid output yun mo, the sum of the 4 ka 15 minutes. For maximal acid output, this is the amount of gastric fluid secreted after nanay stimulation, and this is more important in a way kay makaingon jud ka na muni ang number of the amount yun of gastric acid produced or gastric fluid produced after stimulation or after eating or after naay stimulant. Okay, so duration of collection still the same, 1 hour collection every 15 minutes, especially when you use pentagastrin and histamine, which are mga chemical stimulants, and you have 2-hour collection for insulin hypoglycemia gyapon and histalog, all right, which is another chemical stimulant. So ang MAO is again most accepted expression of gastric acid secretion, because again there is stimulation na. Okay, so makaingon jud ka na because again, diba, remember that gastric fluid is really secreted if naay stimulation or if naay food after digestion. So therefore, ang maximal acid output dito siya makaingon na okay, this is the total amount yun of gastric acid na kung makuha or as a patient yun after stimulation. Okay, kaya ang basal mag yun it's just like without any stimulation. So parang in a way for comparison lang yun siya na purposes. Okay, imuhang basal and maximal acid output. All right, okay. Next, you have the different gastric stimulants. All right, so the different gastric stimulants meaning kanis lang imong ihatag sa patient para maka-trigger imuhang stomach to produce gastric acid. Okay, so you have first the test meals. So, imo siyang ihatag sa patients, all right? And then I think imo siya ipakaon gyud kani siya ng mga meals, and then to secrete the gastric fluid, okay? So you have here the test meal si Ewald's, all right? Na uban dila dears na lami jud kayo mga food, okay? Nakaka-water, nakaka-salivate, okay? Nagama ko sa notes ani kay murag shock siguro manon ko naglantaw. But anyway, napoy uban dito na murag sa mani oy like very very tihik in terms of the food, paras ni Ewald na bread, tea or water lang so mani oy di man stimulate akong gastric di man stimulate akong stomach ani. For BOAs, oatmeal ra, but again this is used for detection of lactic acid, BOA. Ang bet ana kay si Rigel or si Rigel tawa beef steak, mashed potatoes and bouillon. Okay, so girl, my god, ang sarap, ang rich, no? So that's mine and the charot. Okay, menu man di ay charot. And that's a different test meals. Again, the main purpose lang is for stimulation para ma-trigger mo ang stomach to release gastric fluid. Now, another method is of course chemical stimulants. Ayan. So it's either iba ra po siya ipakaon sa patient and then after some time i-collect ng gastric fluid kay siya mo stimulate sa imong stomach to produce the gastric fluid. So you have pentagastrin, the stimulant of choice, all right? You have insulin, histalog, and histamine. Histamine is to assess vagotomy procedure or like kanang if nakay i-open ang stomach or something dira sa intestine, so vagotomy, all right? So you have to assess that, you use histamine. You also can use sham feeding or fictitious feeding. So muna siya nakita dear. So basically, sa mga test animal ni siya or pwede po sa patient. So what happens is murag na opening sa imong stomach, all right? So mukhaon siya, all right? Mukhaon siya pero katupod iyahang gikaon mo gawas ra pod. So mura siya fictitious feeding ba. So murag nakagikaon pero di ay mura pong gipagawas agad-agad. Parang ganun. So fictitious, di gyud siya tinuod na feeding. So sham feeding, scam feeding, charot. Sham feeding ganun. Okay? So again, in a way, to stimulate ng Japon the the stomach to produce gastric fluid. All right? So that's sham feeding. All right, so here are some example of results dears of your bowel and mouth. So imo siyang i-ratio, no? So as you can see, normal ang bowel is medyo little lang. Of course, it's expected kaya wala man siya na-trigger. Kaya remember, basal acid output is fasting. So wala kay food, wala kay chemical stimulant. So therefore, gamay ra gyud ang amount, no, sa imuhang hydrochloric acid or gastric fluid or acid mo rather. For mouth, as you can see, after stimulation na, mas nitaas siya. Okay, and that's the normal. So ang ratio pwedeng 10%. That's just a sample dear sa. Pero expected yun na ang bowel, medyo little siya in number because again, it's fasting. Wala ka na trigger of food, wala ka na trigger of chemical stimulant, okay, to produce gastric fluid. As you can see, pernicious anemia, ako siyang gi-red dears, 0 sa tanan. Nga naman, because again, wala kay parietal cells na destroy na. So bahalag na ay food, bahalag fasting since your parietal cells are destroyed and these parietal cells are the ones producing HCl. So therefore, 0 gyud Japon, wala kay ma-measure. Okay? So very important, pernicious anemia, 0 tanan. Okay? Because kano ganito, na-destroy ang imuhang parietal cells which produce your HCl. Alright? Next, you have duodenal ulcer. As you can see, medyo basal acid output kay medyo elevated. For maximum acid output, medyo elevated. But take note, Zollinger Ellison, kabantay mo, basal acid output palang gani, taas na dayon. Because again, you have mga tumors, no, gastrinomas that continuously produce gastrin. So bahalag ma-stimulate or dili, taas rin yung Japon niyahang gastric fluid na ma-release. So therefore, taas po rin mo basal acid output. So as you can see, siya ang mo-produce og highest bowel and mouth na levels. Take note of that. But sa Zollinger Ellison gani dears, siya gyud ang extreme na elevated. Taas iyang gastrin, taas iyang HCl. Whereas si pernicious anemia, siya ang opposite. Okay? Siya ang low gyud, wala jud ay, walay HCl, no? Walay acidity. Take note of that. Okay? All right. So Zollinger, siya ang taas, no? Taas ang gastrin, taas ang HCl. Si Zollinger siya nagyud. So how do we remember that? Zollinger. Okay. Kung kinsa tong taas og word na lang, ayan. Iyahang disease, di ba, is taas og ngalan. So therefore, taas siya ngalan, taas po siya levels. Taas siya gastrin, taas siya HCl. Alright? For pernicious anemia, siya ang opposite. Wala siya HCl good and wala acidity iyahang gastric fluid. Kaya na-destroy ang parietal cells. Alright? And mubo iyahang value sa bowel and mouth. 0 yun ang pernicious anemia. Okay? Alright. So I hope na gets. Alright? Sige. Next, for macroscopic examination of the gastric fluid, the normal color is pale gray with mucus. All right. Kung na yellow-green, then that could indicate large amounts of bile. Red, there could be small amounts of fresh blood. And coffee ground, medyo meaning na ay brown na in color. So that means large amounts of blood na degrade na siya. All right. For volume, the normal volume is about 20 to 50 in fasting. Greater than 50 is abnormal na if fasting specimen. Okay. So therefore, base na Zollinger Ellison kay daghan kayo siya na-produce. 20 to 60 up to 120 ml, that's after stimulation, so, such as Avoidance test meal, and 45 to 150 after alcohol test meal gyapon. So increase yun siya kaya na may stimulation. Alright? Pero kung walay stimulation, na fasting specimen, tapos taas na yung volume, so meaning abnormal yun siya. Alright? Okay. Now for color again, grayish or bile stained. And there could be food particles na partially or totally digested. Volume again, pwedeng 20 to 100. Odor is odorless or pwedeng slightly sour because of the acid. Food particles again from previous meal indicates obstruction and may give a fecal odor. Meaning, wala gid ni agi or wala siya na add to sa small intestine mohang food particles from the previous meal. So therefore, na obstruction ditong dapita. All right. Reaction, of course, acidic. Mucus normally varies, but large quantity indicates gastritis, no, catarrhal, and you have bile, minute particles as a result of excessive straining while the tube is in the stomach. So possible na ginagmay na bile na masulod sa stomach, pero large amounts of bile is indicative na of upper intestinal obstruction. Kaya ni-regurgitate na siya balik sa imuhang stomach. All right, okay. Next, you have terminologies na lang. Of course, you have the euchloridria. When you say euchloridria, normal free HCl, normal amount, no? You have free HCl. So, ang significance, wala. All right. Hyperchloridria, of course, that's increased in free HCl. Asa na siya makitaan? Zollinger-Ellison disease. Very important. And also, peptic ulcer. All right. Hypochloridria, decreased imuhang free HCl even after gastric stimulation. So that is seen in carcinoma of the stomach and chronic gastritis. Achlorhydria, wala jugkay free HCl. There's an absence even after gastric stimulation. And that is seen in pernicious anemia, also carcinoma of the stomach, and advanced gastric cancer. For anacidity, meaning wala imuhang pH is less than 6 following gastric stimulation, then that is indicative of pernicious anemia. All right. And then we have this test, dears, no? Your Diagnex tubeless test, all right? Or Diagnex blue test, all right? So this is a method in which di na kailangan atong tube, no? Di na ka mogamit og Levine or Refas para ma-measure imong gastric fluid. So I think this is another question na pwedeng i-question or i-ask sa imong exam. Usually ang question na is, what is the specimen? Ayan, naku. What is the specimen used in the Diagnex tubeless test? The answer is urine. You may be thinking na, ay, okay, kay Diagnex tubeless test para gastric fluid analysis. So ang atong specimen ani kay gastric fluid. Of course not, chalk not, yes. It's urine, okay? So unsa day principle ani niya? The patient ingests a blue-colored dye, Azure A, that contains an ion exchange resin. So what happens, pag abot sa stomach, katong mga ions exchange, no? Ang granules, iyahang exchange ang dye for H+ ions in the HCl sa imong stomach. So Azure A is released in proportion to free HCl, which is absorbed in the blood. So again, remember, nikaon kag Azure A that contains an ion exchange resin. Pag abot diri sa stomach, all right, the ion exchange or the ions na nakabind sa imong Azure, okay, mo bind siya or mawala siya, okay, in conjunction sa concentration of H+ ions. So therefore, if mas daghang H+ ions imuhang gastric fluid, mas daghang Azure A na ma-release. Mas daghang Azure A na makit-an sa imuhang ihi. So therefore, the amount of dye excreted in urine is an indicator of gastric HCl secretory activity. Again, blue color dye, Azure A, again, na siya ion exchange resin. All right? So imuhang granules that contains the dye, okay, and the ion exchange resin, okay, pagkita nila sa H+ ion, ilahang kuwaon tong H+ ions, ilahang i-let go si Azure A. So therefore, kung mas daghang H+ ions, mas daghang Azure A na niyang ma-release. Okay? So therefore, mas daghang Azure A na ma-reabsorb balik sa blood and mo-appear sa kidney. So therefore, the more Azure A na makitaan sa imuhang urine, sa imuhang urine, mas daghang H+ ions na naa sa imuhang gastric fluid, mas daghan imuhang HCl. Alright? So take note, unsa atong specimen? Urine. Alright? Unsa atong gidetect sa ihi? The Azure A na dye. Alright? Take note of that, dears. I think mo ni siya. Di ba 2% pa ng gastric fluid? Basin mo ni siya ang second question. I'm praying na mo ni siya ang second question. Okay? So ang question na is, what is the specimen used in the Diagnex tubeless test for gastric fluid analysis? Our answer is urine. Take note of that, dears. Ihi. Okay? Dili gastric fluid. Please naman. Lord. Okay? Alright? Ayan. Sige. Next, this is the Diagnex. Ayan, as you can see. Ayan. This is the parang Azure na granules. Imo siya i-dissolve in water and then imo siya ipa-drink. Okay? And then you have here qualitative tests na lang for free HCl using your gastric fluid. You have dimethylaminoazobenzole. You use an alcohol solution and the presence of HCl, it will give a positive cherry red color. For Gunsberg, you have reagents, fluoroglucine, vanillin, and alcohol. Positive is purple red color. And for Boas, you have resorcinol, cane sugar, and alcohol. Positive kay rose red color. Now for quantitative tests, dears, kabantay mo, it's all about titration. Okay? So for free HCl, for titration, so mong ginagamit, sodium hydroxide. pH indicator nimo is dimethylaminoazobenzole, your top first reagent, and the endpoint is color yellow, canary yellow. Normal value is 25 to 50 degrees or 0.1 to 0.2 HCl. For total acidity, ayan, sodium hydroxide yapon, ang titrant sa tanan. So sodium hydroxide yun. Asa siya mo differ sa indicator and sa color and sa result. So ang indicator for total acidity, phenolphthalein, and for combined HCl, which is bound to proteins, you have sodium alizarin. Okay? For endpoint is faint pink sa total acidity, and for combined HCl, it's violet. And for normal results, 50 to 75 degrees and 10 to 15 degrees. So that's the normal. So mga quantitative. So it's more on titration good. All right. Okay. So for lactic acid, as I've mentioned, it's normally absent sa imuhang stomach or imong gastric fluid. But the presence of this indicates advanced cancer, gastric cancer or gastric stagnation. Because remember that lactic acid may be produced in cases of anaerobic metabolism. So possible na ay tissue hypoxia in your stomach that is a cause of your cancer, or possible po na increased metabolism of the cells. So therefore na mga byproducts such as lactic acid. All right. So how do we determine? Pwede tayo gamit again of mga chemical tests. You have the modified Uffelman's test, ferric chloride and phenol imong reagents. The endpoint is yellow. For Strauss, you have ferric chloride and ether, positive nimo kay yellow, and you have the Kelling's ferric chloride Japon, positive kay yellow. So very press the buzzer lang. The reagents common sa tanan kay ferric chloride, and ang common po sa tanan ang color yellow. Okay? All right. Okay. So that's for gastric fluid. So very short lang yun, dears. That's all for gastric fluid. And for the last is duodenal content. So very short lang yun, one slide lang. So what are the composition of the duodenal contents? Number one is, of course, pancreatic exocrine secretion. Because remember that the pancreas, diretso yung secretion sa duodenum. So pila ka ml? 1,500 ml per day ang gikan sa pancreas. And that's the major contributor to duodenal content. All right. So it's colorless, clear, non-viscid alkaline solution, pH of approximately 8, 1 to 2% organic enzymes and mga precursors ang naa. 1% inorganic kay sodium, ang major cation, and bicarbonate, ang major anion. And we have these hormones, secretin and pancreozymin. Okay. And these are needed to stimulate pancreatic secretion. The second composition is, of course, bile. You have bile duct, ang bile duct diretso sa duodenum. So you have 500 to 1,000 ml of bile that enters the duodenum. It's yellow to brown or green, and usually alkaline with a pH of 7 to 8.5. Bile salts, sodium glycocholate and taurocolate, bilirubin, cholesterol, phospholipid, and of course, inorganic salts. And you have, of course, the enzyme ALP, alkaline phosphatase. That's why your ALP, diba, it's a marker for obstructive jaundice. Okay, so ALP. And you have cholecystokinin, which is a hormone that stimulates the contraction of the gallbladder to increase the bile flow. So that's very very short lang sa duodenum, no? And other components, of course, mga intestinal secretions mixed with gastric secretions gikan sa stomach, and possibly partially digested food. So very straightforward, dali ra kaayo, one slide. So you have to take note lang kani mga kung sa mga composition sa duodenum. Pero feel na ko walay mo gawas sa exam. Sana naman, feel ako magawas good number 1, unsa tong tube, no? Katong mga tube sa gastric fluid, and number 2, unsa tong specimen sa Diagnex. Sana naman may tagtsakto akong feeling. All right? Okay. And that's all for gastric fluid and duodenal contents, di ba? Very straightforward, very short lang. All right? So any questions, dears?